sponsorship of Amil. Thank you very much. Hello to everyone. Now I can see everybody. Hello, good afternoon. Good afternoon, George. Good afternoon. So you do excellent work in public health in our country and in Latin America. It's a pleasure to be here with you. Good afternoon, Rogério Scarabel. We know each other very well. He is the president of the Brazilian Agency of Supplemental Health, and you've been working intensely in the agency, and it's not so easy. And now international guest speakers. Craig Ceppetelli, who has been announced before, and he is the executive director for the International Office of Collaboration of the Royal College of Physicians and Surgeons, and Don Husereau, Adjunct Professor of University of Ottawa. So now, today we are going to talk about Canada. I had the chance of being there. I visited, I got to know your system, and I am absolutely sure that we are going to have a very interesting knowledge or learning journey here. Everything we do in our FIS and this Health Innovation Forum is always thinking about our country, Brazil. So whenever we invite foreign guests and our Canadian colleagues to come in here and talk to us and enlighten us with their model, we also want to know how we can apply what they have done. How could we bring and which of your experiences we could use in your country? That's why after you talk, both Dr. Jarbas and Rogério will make a few comments, and we'll somehow try to draw a parallel between what you do that and which aspects of your model of regulation access can be translated into Brazil. And this is an area where our country can definitely improve. So we can get started without further ado. Who's going to go first, Craig or Don?
It's going to be myself, Francisco. So thank you very much for inviting Donald and myself here today. I had a little bit of technical challenges this morning with the link, but I'm using my phone. So I'm balancing the phone on one hand and giving the presentation with my left hand here. So hopefully it'll be okay and it won't be too shaky. I want to give an overview of Canada first, the healthcare system, the Royal College as an organization, and then I'll turn it over to Donald to give some more discussion points around innovation in healthcare in our country. I'm glad to hear, Francisco, that you've been to Canada. You would have enjoyed it this week. It's very warm, unseasonably warm here, and as we get into the winter months, that'll quickly change here. I'm the executive director for International, and I've had the pleasure of being in Brazil on several occasions. The Royal College is active in Brazil through associations with Unicamp and RMG in Minas Gerais and a few other well-known organizations. Most of our work is around improving medical education, the quality of the standards and examinations and assessments of specialists. And we hope to be back in Brazil in early to mid 2021 once the pandemic has hopefully subsided and it's safe to resume travel. In the interim, we maintain our contacts and communications with your peers across the country, as well as with your diplomatic team here in Ottawa. Your ambassador has been a great friend of the Royal College, and we thank him, Ambassador Borio, for all the work that he's done. So my presentation, I have a slide deck, and I'm not sure if it's being advanced on another screen, but I'll walk through some of the content that I put together. So Canada is a very, very large country. As you can imagine, the size of it geographically, it's a very diverse country from coast to coast to coast. There's 10 provinces, 3 territories, roughly 38 million or so in population, a small city compared to some of of your population, but our country is very spread out. Most of the country lives within 100 kilometers of the US-Canadian border, and most of the population lives within two provinces, Quebec and Ontario. Roughly, 60% of the population lives in those two provinces. We're largely an urban population, with over 80% of our population choosing to live in cities compared to the rural populations or remote regions of the country. Lots of nature between populations here in Canada because it's such a huge country. And that poses some challenges for healthcare delivery in some regions, quality of healthcare, delivery of healthcare, access. We're not immune to those types of challenges. When you look at the Royal College, so the Royal College has been in existence for about 100 years. We were created by a special act of Parliament. I would say, we are definitely an arm's length away from the government. We don't receive government funding. We're not directed by the government in our policies and our mandate or actions. Our number one job at the Royal College is to certify all of the specialists, with the exception of family medicine, before they could practice in Canada. So we regulate the curriculum through the 17 faculties of medicine across the country. So there's a high quality consistency from coast to coast from those faculties of medicine. We also develop and deliver the specialty exams and the subspecialty exams. Those exams, if successful, allows the physician specialist to practice in Canada. Without that Royal College designation, it's difficult for them to practice their specialty in our country. Of course, they have to have the provincial licensing and certified checks and balances from province to practice, but the Royal College designation is key to their ability to practice. We also do a lot of policy and advocacy work within the Royal College around Aboriginal issues, opioids, artificial intelligence, and other policy matters that impact the Canadian healthcare space. There's two colleges in Canada. There's the Royal College of Physicians and Surgeons of Canada that oversees all of the specialist training. And then there's the College of Family Physicians of Canada that oversees the family specialty. They have their separate college. Many, many years ago, about, I would say 40, 50 years ago, we were all underneath one umbrella, but we decided to part ways and have family medicine have its own separate college. I'm going to get into a little bit of the demographic makeup of the workforce in a subsequent slide. But again, our reason for being is really to ensure that quality of education from coast to coast, to ensure that the specialists are well positioned to deliver the best quality care to Canadian citizens. However, we have a very strong international slant as well. Our strategic plan, which is wrapping up in April of 2021, had international engagement as a cornerstone of our mission. We engage international partners in very select countries, and we have about 35 different national partners, international partners that we work with in Latin America, the Middle East, Southeast Asia, and abroad, elsewhere, in areas of mutual collaborative benefit, I would say, in that being the number one goal being to improve postgraduate medical education and lifelong learning. And we want to be perceived as the global leader in specialty medical education and care. That's our current vision. And we live that every day through our day-to-day activities here domestically, but also pursue that in our international endeavors. If I can get the next slide, I think we're going to be talking about our healthcare system at a glance. It's a bit of an overview slide. The Canadian healthcare system on the next slide, it states that we are a publicly funded system. The government funds the healthcare system in Canada, but it's delivered through private means, physicians and hospitals. The majority of all of the medical procedures that happen in the country are approved and are funded through these provincial and territorial government funding programs. Now, of course, the Canadians pay into these programs through their taxation policies and regulations, but the government does administer the healthcare through that system of public advocacy, public oversight. It's a constitutional responsibility essentially of the provinces and the territories to provide healthcare to all of their citizens. So no citizen should be left behind when it comes to healthcare, much like other, different from other jurisdictions like the United States, where you may not have healthcare coverage. In Canada, everybody should have equal access to healthcare and equal quality of healthcare, and that's an underlying, cornerstone of our healthcare system. The federal government certainly assists in the financing of these of the system, the healthcare system in Canada, and it has taken specific interest in specific special groups that have special needs, like the veterans, like Indigenous populations. We have some very significant healthcare challenges and inequalities that we're trying to remedy in Canada in our Indigenous population communities, and Canada is trying to resolve those challenges. Same with our veterans. We have special systems in place to provide healthcare for our veterans who are served in the military. But by and large, all the members of the public's community in Canada have access to good quality healthcare. You may have to wait. There are wait lists that are challenging to many of the Canadians who are seeking healthcare. But at the end of the day, when you do get healthcare, it is of high quality and high dependability and a high level of trust and confidence in it. Next slide, please. I think the next slide will actually speak to some of the foundational, I call them cornerstone topics or items that really guide our healthcare policy. What I really want to touch upon, again, is the equality, accessibility, and the portability and the universality of our healthcare. So whether you are in the East Coast, West Coast, or Northern or Southern regions of Canada, you should be able to get treatment for any condition that you may have at a time when you need it, and certainly at a quality that you expect. And that's really an underlying, philosophy for Canada, is that healthcare is a human right, and that we should be ensuring that all of our citizens have access to that basic human fundamental right, which is not always the case in many of the countries that we work in and engage in. There are some healthcare quality and accessibility disparities that we see, and it's a shame. From a demographic point of view, the next slide will get into a little bit of our the makeup of our healthcare system on the medical side. I didn't talk about nursing or allied health in these slides, but from a medical point of view, there's roughly 50,000 specialists outside of family medicine. So orthopedic surgeons, oncologists, pediatricians, and they comprise about 50,000 clinicians across the country. An equal number have taken the specialty of family medicine and established practices across the country. So there's roughly 50,000 family physicians across the country. And, when you get into, the gender balances or those that have taken their studies in Canada versus international, you'll see some additional statistics on this page. We have a very diverse healthcare field, I think, in terms of training. When you look at family medicine and the medical specialties, it's 25 to 30% of our specialists have trained outside of the country. The United States probably being the most dominant, followed by some of our European countries. In Canada, on the other side of that coin, we bring in a lot of foreign resident trainees into Canada to conduct their specialty training. I believe it's roughly 2,000, 2,500 international resident trainees come into Canada to study those specialties here within our faculties of medicine. The vast majority of which go back home at the end of their training cycles. It's well into the high 90 percentiles that return back to their home countries to continue their practice. But that gives you a bit of an overview of the spread of the specialties in family medicine, the gender diversification, and the international mix of our training here in Canada. This slide. When it comes to spending in Canada, it is not obviously a cheap system. The spending in healthcare on a per capita basis has been increasing rather steadily. It does comprise almost 11% of our gross domestic product. And most of that money, 75% of it, is funded through the public sector the government bodies that we mentioned, the territories and the provinces. So the total dollar spend in 2015, and these are old numbers, is roughly $220 billion on healthcare spending a year for our citizens. And again, we have a population of around 38 million. So, there is a significant amount of money being invested in healthcare. I would say that I heard a statistic just recently that most of our hospitals are operating at about 110% capacity, so they're already stretched thin. We have an aging population, like most North American countries and Western European countries. There's an aging population. There's a need for long-term care solutions to take some of the pressure off of our healthcare system. So these are some additional challenges that we are trying to solve through some of the innovation means that might be discussed in the next slides. But it is a huge issue in Canada, this aging population, the increasing fiscal requirement to support the healthcare system. The demands are certainly outpacing the supply. The next slide, if you will. This might be where I'm going to turn the presentation over to Professor Husereau from the University of Ottawa, and Donald will walk you through some of the technology innovation side of the healthcare space and how that gets integrated into the healthcare system and the policies around that and the regulations. Donald?
Okay, thanks, Craig. And I hope you can hear me well. We can go to the next slide. Although I can't see the next slide now. But I think it's introducing myself and what I hope to address here. So I was asked to speak specifically about technology. How do we regulate access to new medical technologies, particularly technologies that are needed for routine care? I've also been asked to address how we guarantee access to new technologies, and I was given the mandate of speaking about diagnostics and therapeutics, and also issues that might remain in Canada in regards to technology management. So I can speak about those things. Next slide. So I stole this just from Craig, but it's to reinforce the idea that Canada is a federated healthcare system. Which means, as he mentioned already, all of these provinces are agreeing to use, to deliver healthcare according to the principles laid out in the Federal Health Act, and which means that each province has to decide structurally how they're going to organize themselves so they can meet those mandates. Most provinces have chosen very similar approaches, but there are notable differences between provinces. And I can speak a little bit further about that. So the next. So just to make sure it's clear, Craig mentioned that services are paid for by provincial and territorial governments. However, these healthcare services in that federal mandate are hospitals and physician services. And that leaves a lot of other types of medical services kind of off the table. And so provinces have chosen different approaches of how to deal with this. For example, public insurance, community-based drug insurance is not a part of the federal mandate. So obviously, each province has had to decide whether they wanted to introduce universal pharmacare coverage or simply to introduce social public insurance programs that will address, for example, the very young or those without employment, etc. And each has taken their own approach. And there's similarly no public mandate for other technologies like vaccines. We have a federal public health agency, and each of the provinces have their own public health offices, and they decide on their own vaccine schedules, although very highly coordinated centrally through a national body. Quebec has its own distribution system for certain types of things. Similarly, something like a point of care device, which might appear in a doctor's office, or any other technology that exists outside of a hospital, it does not fall under this federal mandate. So it becomes a different approach depending on the province. And I'll go to the next slide. I mean, what all of this means is that it's actually a fairly complicated system in a way. We do have a federal regulator who decides what medical devices and new technologies are allowed in to the country, can be marketed, but then each provincial ministry has to take its own approach. The provinces may have a health technology assessment body that helps inform decisions, but the majority of technologies are actually used in hospitals. And in those cases, the hospitals, or sometimes a regional health authority of a number of hospitals, have to make those decisions independently. They are provided a finance envelope. And if we go to the next slide, I can explain how technology then is regulated through financing. So in the case of hospitals, all provinces have basically taken the approach that hospitals, which are private, not-for-profit institutions, are provided a budget envelope, a set amount of funding based on their historical performance, their catchment area, what types of patients they're serving. And basically, there is a funding formula that simply accounts for the service that they're providing from year to year. There are no special funds given for technology. So essentially, hospitals are left to their own decisions about what technologies they want to introduce and how to introduce them. And you can imagine this type of budget envelope arrangement greatly constrains their ability to adopt very expensive technology. You have to remember as well that technology, medical devices, are simply a portion of the costs associated with technology. When we introduce a new technology, almost in all cases, we introduce the need for more human resources to service the technology, operational costs. Technology is one of the greatest contributors to expenditure growth, and yet in Canada, we're not monitoring its overarching impact. So any hospital that has to make decisions about whether to introduce a new procedure or a new device like a portable ultrasound in an emergency department has to decide whether it actually can also support the operationalizing of that technology. Can they support the nurses or the additional training or all the other things that are required to support the technology? Craig mentioned physicians are paid under the Canada Health Act. So in each province, there's a physician schedule of services, and that means that physicians act as free agents working within hospitals who are paid for their service, but the fee that's used to pay their service, for example, if they're doing a radiological procedure, is not a fee to cover the consumables of the technology. The hospital must cover that through their envelope budget. The hospitals also have to pay for expensive capital equipment, and as you can imagine, given their existing budgets, they either have to do that through private fundraising to help supplement their budget, or they have to take opportunities from, for example, a provincial special program. And there are some technologies they're simply just not allowed to build without permission or without seeking approval from a provincial authority. Well, you can't simply just buy a proton beam therapy device, which is a $10 million capital equipment expenditure, without checking in with the province and accessing that through a special program. And unlike the US and some other countries, we don't have specific codes related to procedures and technologies such as DRG codes. So if a new technology comes in, it's not the hospital that has to create a new DRG code. The hospital just has to decide if they can fund the technology, particularly the operational expenses of the technology, given their current budget envelope. And this is where most technology occurs. And so you can imagine that given the funding formula and given how technology contributes to expenditure growth, this minimizes the introduction or adoption of new technologies into hospitals. Now, what about technologies outside of hospitals? Well, physicians are free to, use or purchase new technology, for example, a point of care device, but they're not provided any special funds for that. So they have to take money from their own fees to cover any kind of procedural costs, etc. Or if it's not considered a medically necessary service, they can use a technology and they can pass on the cost to the patient. But of course, most physicians are not necessarily interested in doing this. There are also other technologies, obviously, that are used to support community-based physicians, like laboratory services, and typically these are covered through special programs. So in most provinces, community-based laboratory services are covered through a specialized program. It's not mandated under the federal Canada Health Act. However, obviously, it's something that physicians need. And so provinces now have begun to organize themselves with schedules or formularies for laboratory testing, and they're becoming much more concerned about what new tests they adopt for these schedules. So again, if a physician wants a certain type of test done, if it's a highly specialized test like a genetic test, there will be a specialty program that is considering the use and adoption of these tests. Typically, a highly specialized genetic test would be done through a hospital. Finally, there are other technologies, obviously, that are used to support physicians, like community-based drugs or a dialysis program. Again, these are usually specialized programs that the province sets up and manages. And so that the program-related technology costs are managed much the same way as a hospital, where the program is given a set budget and provided a small amount for expenditure growth. But that doesn't mean that, for example, a dialysis program can just go crazy and buy 100 home-based dialysis units whenever they want. They're working under a socialized budget. So that also means that new technology has to be considered on a one-by-one basis. Now, I did mention that some provinces have provincial-based HTA programs. It's typically the bigger provinces: Quebec, Ontario, British Columbia, and Alberta. In Quebec, in fact, they have a provincially led technology assessment program that also covers social services. And they have mandated in law that the academic centers or the tertiary care centers must also have health technology assessment programs. Ontario has a province-wide health technology assessment program. They also have some hospitals that have HTA programs, but it is not a provincial mandate. And Alberta and BC to some extent have also health technology assessment programs, usually used to inform large technology decisions, like, for example, the use of a new and expensive application for PET scanning, for example. Other provinces that don't have HTA rely on our national HTA program. We have a CADTH, National Technology Assessment Program, which is the Canadian Agency for Drugs and Technologies in Health, and they'll provide information and advice to their provincial funders. However, any advice they provide is not necessarily binding advice, and clearly hospitals are private, not-for-profit entities, and they can do what they wish. So they're not mandated by either a provincial or a national technology assessment program. However, they can be enabled by it. If a province decides that it's something that they're willing to fund, it becomes easier for them to adopt because there might be a funding mechanism built in. So I'll go to the next slide and just talk briefly about challenges. So from my last point, we do have technology assessment, and you'll recall that, for example, in PAHO, technology assessment is something that has been ratified as something that Latin American countries need to adopt. I know we have somebody who can speak about this further. So despite having these technology assessment programs, they have very little impact on the flow of technology. Technology and the adoption technology is much more easily managed just simply by using finance mechanisms and the structure of financing. Hospitals are incented to fund medically necessary services. And we do see some hospitals that will adopt technology more so than maybe makes sense from a funding standpoint, but they usually do this because they want to become leaders in either research or in that technology. For example, we have a hospital in Ontario that adopted 5 robotic surgery units. But they simply wanted to be the hospital that is the leader in Canada, if not North America, in robotic surgery. So technology decisions are made by administrations in hospitals who have to consider budgets and opportunity cost from technology. And technology availability is also greatly influenced by how the purchasing power of a hospital. Many hospitals get together and they're able to buy consumables or technologies through group purchasing arrangements. So we see technology also enter or facilitated by these tendering arrangements that drives costs down quite a bit. And we also see technology adopted and facilitated by research programs. So I mentioned the robotic surgery, but in testing, this is very common, where an expensive genetic test will often be developed and even delivered through the context of a research program. So I'll stop there because I think we're meant to take questions. Thank you.
I'm hoping you can see me and hear me okay.
Espero que
Tem razão, vocês mandaram desligar o telefone, desligar o microfone, eu desliguei, agora desligar.
So my mic was off and now I forgot to put it back on. And well, I'm not using technology appropriately. But your presentation was very good. It was a guideline for what you do in your country. And we somehow are going to, with our 2 experts, we are going to try to think what happens here in Brazil and how we could use your experience for technological incorporation in our country. And then I am going to tell you a little bit more of what can be done in the public industry, and Scarabel will be working more on what we have here for the private industry. So first, you...
Como quiser.
Jorge,
Tá bom. Tá, muito
obrigado. Qual que é seu?
isso. Muito obrigado, Francisco.
Good afternoon. Thank you very much, Francisco, for invitation to be in this meeting. I would just like to clarify something. It said that I am in Pajo. I'm not representing Pajo in Pajo. There was someone who was from Pajo, but because of agenda problem, he couldn't be here. I'm not with Pajo. I am a FIOCRUZ researcher, so I am speaking on myself, on my personal vision, and my visions do not reflect the opinion of FIOCRUZ and not of Pajo. But first of all, I would like to praise Craig and Donald for the brilliant and very good vision of the Canadian healthcare system and technology incorporation. And you have a problem with the geography and extension. And this is very complex, and we have it here too, this type of problem. The north region is very different from the southeast, center, west, and south. So Brazil is too a very big country, and there's a complexity that needs to be addressed. So first of all, in terms of access to healthcare, and of course, access to technology. The role of the Royal College that Dr. Ceppetelli mentioned to us is fundamental, but we don't have anything similar here in Brazil to watch, nothing like the Royal College. And it's very interesting and very important, but we don't have anything similar. And from what our colleagues from Canada have mentioned, your system is different because you have public funding of the private system. And here we have a public government-funded and a separate private system. So there's a difference here, and they have different funding sources, and they complement each other in terms of resources and funds. What we see in Canada, it's excellent federal coordination with a very strong work by the provinces. We are too a federation, and our healthcare system has 3 different levels or 3 different government levels: federal, state, and municipal. And here in Canada, we can see how important it is to have federal regulation, as they said. So I would like to talk about the regulation of access with the Brazilian model as a country with 210 million inhabitants, as a universal and free of charge healthcare system. First of all, we need to have assumptions and references that are very clear for us to do that. Globally speaking, we need to mirror the 2030 agenda, the Sustainable Development Goals, and Goal 3, which is assure healthy life and well-being of everyone. And as to the incorporation of technology, we have Goals 3.8 and talking about access to medications, and also research and development, and certain legal devices to protect public health. And our difference is unquestionable. So in my opinion, we don't need to review it. We just need to meet our what we have. So we had our constitution assuring health as a right of all and a duty of the state. And we have the law, the regulation creating the national healthcare system, including comprehensive care for the public healthcare system. Traditionally, SUS effectively implements the complementarity between the public and private systems. So these actions, in combination with the strengthening or to have the industrial economic complex of health, they are our references. And this has been emphasized in the last health conference. So health is a priority, and there was a very intense discussion related to science, technology, and pharmaceutical care. And I would like to draw the attention to the importance in our healthcare system for the structures for the incorporation of technologies, especially the National Commission of Technology Incorporation, CONITEC, and the Ethics Research Committee, that is national, a research ethics committee that is national. They are very strong organizations and very active and very important. I would also like to remind you that Brazil has already been a reference and a model for the world in many areas, including in pharmacochemical production. We had the Brazilian company of antibiotics, producing antibiotics and exporting antibiotics. We had Biobras producing insulin, also a very big structure. And we also we were references in reverse engineering to produce antiretrovirals that did not have patent. And we also have local production that was implemented here, and importance of public pharmaceutical companies and the partnerships that are partnerships between private pharmaceutical companies with technology transfer to government-held pharmaceutical companies, bringing technological incorporation and structure and technology and know-how to Brazil for the production of the raw materials and for the formulation of medications. And one recent example that we have had, well, it's not really recent, was the mandatory license in 2007, and the only one we had in Brazil for antiretroviral for efavirenz. And when it was implemented, it drove prices down by 5 times in comparing what we had to buy overseas and what we manufactured here, an incorporation of technology for us to manufacture this in Brazil, and we're still doing there, even at Fundação Oswaldo Cruz. So I think that our recent past has many accomplishments, and many of those are being disassembled, or we have a severe problem here in our country, and I would like to say that and being very honest. 95 amendments to the Constitution, when it freezes public expenditure for 20 years, really chokes the public sector. So what we are taking down are the so-called low-income drugstores and other programs that have worsened and indicate a worsening of our situations, and some structures are being put down. And when the pandemic comes, the coronavirus pandemic, it's a much severe challenge which increases social inequality in Brazil. Because technologies that are directly related to fighting the coronavirus, they have been adopted in Brazil and all over the world. Many measures for the protection and recovery of health have been adopted. And these non-pharmacological measures, including isolation, social distancing, quarantine, EPI. And this definitely changes our social life and commercial activities all over the world. So these measures make even more vulnerable our homeless populations, unemployed populations, sub-employment, informal trade, and thereby the levels that we have, not just in Brazil, but in all our countries, there are social imbalances that were aggravated with the pandemic, in addition to overloading our public health system. And there are many elective surgeries that were not done because there was not enough space in hospitals because of the need of providing care to COVID-19 patients. And we also had an increase in the number of specialized beds that really are a burden or an overload for the public health care system. There is something very clear. The public sector is saturated, and the private too. There are COVID-free areas and COVID areas, but really our system is overflowing, and this has been aggravated by the COVID-19 pandemic. And I would like to address something that I find very important, which are some barriers that we have in access of our populations to medical technologies. And then I would mention pricing. And there's the difference between cost, value, and price of technologies, medications, vaccines. So we do not have a direct relationship between cost and price. And there are many examples all over the world and in many countries demonstrating how prices go down, and we see that the production of generic drugs, once prices go down, it increased the number of people that could have access to those products.
Agora, eu quero ressaltar aqui iniciativas
But I would like to emphasize some
entre os quais eu queria
initiatives in some countries, and I would like to highlight Canada. Canada, both our colleagues did not mention DOC 13 of March 25th that amended the patent law in Canada to allow that the Patent Commission, by determination of the Ministry of Health, could issue mandatory licenses for public benefit. This is a measure that was adopted in Canada and also by other countries. In Germany, and they're not countries in our region, Germany, China, Ecuador, and others, also are having more flexible to eliminate the patent barrier to have access to technologies while the pandemic is going on. And in the global scenario, there are many initiatives, and we see that there is a dispute between solidarity and also unilateral initiatives of many countries of buying products, like a competition, a market competition. And we're seeing this being done with vaccines currently, but also with any other product that could potentially be used for the pandemic. So we see a recent movement in the World Trade Organization, that South Africa and India, with the support of Kenya and Swaziland, have asked for a waiver, temporary waiver, for patent protection to all technologies related to the pandemic. And this was supported by many countries, but also some countries didn't agree. There will be another meeting now on the 20th to see if this proposal will be adopted or not. And what gets my attention is that many countries such as the United States of America and the European Union, UK, Switzerland, were against this measure, as well as Brazil, in a way which is contradictory with its past of defense of human rights that Brazil has had in the recent past. So this led to a letter written by the Brazilian society, written by more than 60 organizations and signed by many scientists and researchers and everyone, supporting, endorsing that initiative of the World Trade Organization. Along the same vertent, and in closing, a group of 11 congressmen here in Brazil of many different political parties, different positions, they initially submitted on April the 2nd a bill, Form 62, similar to what Canada does and similar to the waiver that we are discussing for Africa, to grant officially a waiver in emergency cases to the compulsory license for patents or patent applications for products related to the pandemic while the pandemic goes on and while we still have the national emergency state or international emergency situation that the WHO has declared. So I would like to close with one piece of information which is very clear to justify why this is being asked in Brazil and also internationally. There was a survey done in May in Brazil of patent requests or applications. And then they found that INPI, we have today pending 11 patent applications for vaccines, 72 patent applications for medications, and 141 patent applications for diagnostic methods, all of this related to COVID-19. So these are technologies that could help, and if they have the patent, if there is a monopoly, the prices could be higher, would not provide access to everyone. And we know that not protecting patents makes it possible to have patents to manufacture generic drugs and for more people to have access. But then on the other hand, one piece of information that really caught us by surprise is that in consulting the database of medication patents that is in Switzerland but works with medications and intellectual property and the WTO and other organizations, they found that today in the world we have circulating more than 2,000 patent applications related to medications for potential use for COVID-19. So this is a market where there's a lot of dispute, there's a lot of competition. The industry really wants to place its products, but putting its products with protection so that there is no competition in the market. So I would like to close. What do we expect from technologies that are related to dealing with the pandemic right now, not just in Brazil? So we want them to be global assets and with market disputes. This is what we are saying ever since the World Health Assembly, and then the vaccines produced in China are going to be global assets. And then there was an attempt of changing technologies and considering the technologies produced for the pandemic as global health assets. And there is a very fierce competition in some places, and I need to be fast, and we have discussing a lot in Oswaldo Cruz Foundation, and we report to the Ministry of Health that we need to have above anything transparency and social commitment and appropriate information, and this must guide our actions and our narratives, especially at the time of pandemics, because at times of pandemics, we need to remember that emergency situations also require emergency measures and emergency solutions. We can't address technologies related to the pandemic as we treat the rest of the pharmaceutical industry. We need to have a strategic and emergency behavior to deal with our pandemic, and I thank you very much, and I can continue our debate.
You see, amazing, so much information, really. I think you have given us a very broad presentation and an overview of what we have to analyze and consider. Thank you. It was like an MBA, just so much content. Okay, let me now hand it over to Rogério, please. Let's see what we have to hear from the private sector. Thank you. Good afternoon, everyone. Let me greet and thank for the invitation. Thank Josier and Balestrin. Let me greet Don and Greg and Jorge. I would also like to greet all the members of ANS, the private agency here, private health agency here supporting us. I think we have seen all the overview and the comparisons of Canadian and Brazilian health. So I'm going to talk about the private healthcare agency and how we regulate things here in terms of technology incorporation. Our main interest is to defend the public interest. We are responsible for regulating HMOs, insurance companies, and the relations between providers and consumers, contributing to healthcare at large in the country. So we set the rules, best practice, we coordinate, and we regulate the HMOs and consumers, and to some extent, also with providers. So ensuring solvency, structured information to the population, so that we can offer the appropriate products delivering what was part of expected good care, timely care. And we run a number of campaigns to reduce unequal access to information or uneven access to information, so that consumers can be more aware and more knowledgeable about health at large. So this is the purpose of our policy and our goals, always focusing on sustainability of the industry so that beneficiaries can have access to new procedures, new technology, things which are appropriate to patients at affordable cost. Private healthcare in Brazil has a very complex characteristic. There are different kinds of healthcare plans. They can be individualized, so people can buy it as an individual or for family. We also have affinity plans. We have corporate, large group based. You can buy products just for hospital care, outpatient or inpatient, outpatient care, with or without obstetrics. And we also have dental plans. Some plans are cover the whole country, others are just state-based. And we have free choice of providers, or we can have a credentialed network of providers or verticalized network, copay, without copay, deductibles, etc. There are some with our self-management companies. We have medical cooperatives, companies, dental cooperatives, and also some HMOs. It's a very complex industry, of course, robustly divided. So we have 47 million lives covered by private healthcare plans. During the pandemic, many lives were lost, many beneficiaries were lost, and now we've just recovered what had been lost during the pandemic. And we have 116 different HMOs and 360 in dental care. So 116 medical care, 360 dental care. About 207 billion was the revenue in 2019. 1.6 billion procedures, or 6.4% more of utilization comparing 2018 over 2019. It also generates a lot of jobs. This is an industry that has a lot of jobs. We have 3.3 million jobs in private healthcare and 1,100 in the public arena, so total 4.6 million jobs between private and public sector in Brazil. Now let me tell you about technology incorporation. We do it because it's part of our mandate. It's a legislation for the healthcare plans from 1998. 2 years later, a new law was passed concerning the creation of the agency. And on Clause 4, it says that the National Agency of Health is responsible for preparing a list of procedures and health events. Exactly what is the minimum required coverage. All healthcare plan insurance, regardless, should at least provide the minimum required coverage, which is reviewed and determined by the National Private Agency. There are 125 guidelines of use, 3,000 plus procedures, and 43 antineoplastic drugs, which are of required coverage. In addition to, of course, medical visits, diagnostic tests, surgical treatment, chemotherapy, radiotherapy, and oral antineoplastic agents, in addition to any medication that would be applicable to adverse events related to antineoplastic agents. The legislation has set a number of assumptions for the incorporation of technology. First, the alignment with national health policies. In 2018, a new regulation was passed, so everything aligned with CONITEC. CONITEC is the committee that analyzes the incorporation of new technology. So promoting health and prevention of diseases, something that would be really appropriate for offering the best healthcare to citizens. HTA is what we use as a reference. So we have parameters for efficacy, accuracy, efficiency, safety. Whenever any technology is submitted to us, it's going to undergo an HTA, and we are also going to rely on evidence-based data and all the references that can be found. We update our list of procedures and technologies every 2 years. Right now, we have an open public hearing running, and it's going to be ready, fully revisited, to be put into effect in March. In March, we are going to have the new list of everything approved. And we do it every 2 years so that we can have appropriate legal safety and a transparent and logical process. Anyone can submit a request for approval of new technology brought to our attention. We run an HTA, and we gather scientific evidence concerning efficacy and effectiveness. And we also observe how the professional boards analyze and consider that technology. So it's done very transparently so that we finally can come to a decision of incorporating or not the technology into our list of procedures and technologies. This is something that meets the needs of our patients. We want to incorporate new technologies that would be beneficial to our users, really providing sustainability at the same time of the whole system. Right now, 1,300 submissions were made to us to be considered. Out of which 215 were eligible. And right now, it's open for public consultation, as I told you, up to November 21st. So we have 215 of these submissions open for considerations and analysis. So there is the submission, the context, the technology, a summary of scientific information, everything that has taken place in the technical meetings. We had 27 technical meetings, everything webcast live. It's available also through YouTube on our web page. So I encourage everyone to join us in our public hearing, give us your opinion, your contributions. And during the pandemic, there were 3 extraordinary inclusions of technology. So PCR tests for COVID, real-time PCR for influenza A and B, and finally IgG antibodies and total antibodies serology test for COVID-19. So thank you very much for your attention this afternoon. Hope I have met the needs and the interests of our organizing committee. Thank you.
Very well. It was great. I like when you explain. You're very didactic. And it's very interesting to hear you, and anyone can understand what you mean and how the agency works and everything you do and how it positions itself. Of course, you have seen there that our time is up. So we have another presentation right after we close. So we're going to say goodbye But I'm not going to leave our Canadian friends to come all the way to Brazil. And we hope that they answer this in 1 minute, please.
Great.
Don, here's the thing. A movie that was very popular here in Brazil many years ago was Barbaric Invasions, that talked about everything, all the way between patients to use technology in Canada. And it was very difficult. It seemed like martyrdom. Is it still like that, or has it become any easier? Is it still as difficult as we saw in the movie?
Well, I think it was a movie, so it was meant to be a bit of fiction. But in the province of Quebec, where it was based and where the director was from, Quebec has taken a very socialized medicine approach, very top-down approach to managing care. So at times, they have had struggles with medicine, that kind of thing. But I don't think it's that bad. And we have to bear in mind as well, there was a lot of information and disinformation about the Canadian healthcare system, aided in part by admitted efforts to discredit public healthcare by U.S. private insurance-based organizations. So there are a lot of people that think that we wait too much, we're dying in line, but in fact we have very good care.
Muito bom, Dom.
Very good, Don. Thank you very much for your answer. George, thank you very much. Rogério, excellent. Thank you. I think that our other Canadian friend must be away already. And thank you very much for the audience. And my digital greetings to all of you. Thank you very much for the opportunity. Thank you.